Right, hello everyone. I think, unless Caroline tells me that we're not, we're live. So welcome. Thanks for joining us for this Health Foundation webinar on how the NHS compares to other health systems and what we can learn for policy in England. I'm Hugh Alderwick. I'm Director of Policy at the Health Foundation, and I'm joined by a great cast of speakers, panelists who are going to help us make sense of tricky big questions this morning. So we've got Mark Pearson, who's Deputy Director of Employment, Labour and Social Affairs at OECD. They're the organisation we often look to for the data on how the health systems do in England and other countries. We've got Irene Papanikolaou, who's Associate Professor of Health Economics at the LSE, and whose research focuses on assessing performance of health systems, including a great new book for the EU Observatory on Health Systems and Policies I'd recommend you read. And Tim Gardner, who's a Senior Policy Fellow here at the Health Foundation. Tim works on all things NHS policy, but also leads a lot of our work on international comparisons. So the focus of the conversation today, if you're in the right place, is on the overall performance of the UK health system, how it compares to others, and probably most importantly, what we can and what we can't learn for debates about NHS reform, NHS policy here in England. In lots of ways, these questions are nothing new. There's a long-standing interest among researchers, policy analysts, in the media, in the newspapers, about how good the NHS is compared to others. People are interested in how much we spend. Do we get good value for money? What aspects of our system might be holding us back, like limited investment, low numbers of doctors or nurses, or whatever else, depending on your interpretation of the data. And often people want to know how we rank against Germany, France, US, other health systems. While the questions aren't very new, they're currently high on the political policy agenda here in England. There's lots of interest about how we can improve services after the pandemic, particularly given the big pressures facing the health system right now, pressures in general practice, people struggling to access some services, and 6 million people waiting for routine hospital treatment. There's clear value in learning from other countries about how we improve our system. We know that Europe, America, elsewhere are facing similar challenges. But the tricky bits is that comparing health system performance is super hard, notoriously tricky, and the data can often get misunderstood or misused, which can lead to some dodgy recommendations for policy. Standing back, there's also some big limits on what we can learn from some of the headline data, say on spending or quality, without getting under the skin of the context of different systems, why they're different, what the political choices are. So the idea of the session today is to try and make sense of some of that stuff. We're not going to answer all of those questions, but to give a bit of a rounded, objective overview of how the NHS does in some key areas, and then talk about what the data tell us, what they don't tell us, and what it might mean for system reform in England. So before I hand over to our speakers, let me just quickly tell you how we're going to run the session. So we're going to start off with a presentation from Mark. He's going to give an overview of how the UK health system compares to other OECD countries based on their latest data, giving a bit of an assessment of some of the implications, for instance, on spending. Then we're going to go to Irene and Tim for some initial reflections based on their work and based on Mark's presentation. And then we're going to spend probably the second half of the session on questions for all three of the speakers. Then we'll wrap up the discussion about 12. So we've got quite a lot to pack in. Please do submit questions as we go, even through Mark's presentation. We'll be able to see all of them. We'll choose the questions that seem like the most reasonable to ask. We'll ask them. And there should be a box to submit questions at the bottom of your screen. Two last things: the session's being recorded. It's going to go on our website in the next 24 hours, I'm told, presumably so you can watch it all again tomorrow. And then second, if you want to tweet, good for you, go ahead and do it. There's a hashtag that's NHS reform, I think.
We've lost Hugh. Well, maybe, do you think he was coming to the end of his introduction? I think he probably was. So why don't I go ahead and actually start my presentation rather than losing time waiting for him to come back. somebody from the foundation argue if you think that I'm doing the wrong thing. Yeah, okay, very good. In which case, let me share my screen and let's get going. As you can hear, I am English, but let me say straight off, I haven't lived in the UK for nearly 30 years. And so whilst you may think the accent means that I'm somehow deeply in the NHS debates, understands what's going on, no, if I'm very much an outsider looking at the OECD, looking at the UK from an outsider's perspective. And in that, from that perspective, I actually do find some of the discussions in England, in the UK in general, quite parochial in some respects and quite unrealistic in other respects. But what I've been asked to do is to talk today about health system performance. In the UK, I will be talking about UK, it's getting harder and harder, isn't it, to talk about the UK. Obviously, a lot of this is really about England, but not entirely. So how does it stand internationally? Now, the way I'm going to do that, I'm actually going to go back to 2019 for a lot of the comparisons I'm going to do. Obvious reason why 2020, 2021, we are deeply in COVID, and some of the statistics that we're collecting from countries, they're going to need a lot of interpretation because health systems have operated in different ways. I will present some numbers about the COVID response, but a lot of what I'm going to do talking about how does the UK stand is going back to 2019. Just because that's, I think, the most comparable data. And so how should we do this? I mean, Hugh's already said it, it's extremely difficult to cherry pick, or rather seem it's extremely easy to cherry pick a set of statistics, one set of statistics, and say this shows that the UK is doing incredibly well or incredibly badly. And indeed, it's very frustrating for us who do international comparisons because there is no easy answer to any of this. So what we've actually done in the UK, in the OECD, is to look at our various statistics and come up with a set of indicators that we think collectively give a clearer picture of what's going on in health systems. And I'm going to show you some of those to begin with. At least I will do if my, oh, there it goes. So set of indicators, all of which have been normalized. So in other words, basically, you'll see on the right-hand side, the average numbers should make sense. If you look at them, life expectancy, UK 81.4 compared with the OECD average of 81. So you can sort of make sense of the real numbers, but we've normalized them to show how different they are from the OECD average. Now, I'll remind you, the OECD consists of essentially the European Union, plus a few of the European developed countries which aren't members of the European Union, North America, increasingly South America, so Colombia and Chile are in there now, East Asia and Australasia. So when you're comparing to the average, if you're at 0, you're basically on the average. +1, you're doing 1 standard deviation of those 38 OECD member countries better than the average, -1 worse. And they grouped them into a series of 5 different areas. The first lot being health status. How is UK doing on health status? Well, you can see most of those numbers are very, very close to 0. So pretty much exactly on the average for the OECD for things like life expectancy, for things like avoidable mortality, self-rated health, all exactly on the average. The one difference is on chronic disease morbidity, where in fact, UK does rather well. Better than 1 standard deviation from the average. But overall, most of those indicators round about the average. Then when we come to risk factors, how many smokers? Essentially, it's the average for the OECD. Alcohol, essentially the average. Obesity, yes, it's worse, but not more than 1 standard deviation worse. Air pollution, basically around the average. So risk factors, pretty average. Access to care, population coverage, nearly all OECD countries have full coverage. Obviously not the United States, 1 or 2 others, slightly less, but basically UK is normal there. Financial coverage, yeah, pretty much average. How much of your health spend in the UK is covered by prepayment, that's compulsory payments to social insurance or taxation, pretty much average. There you see 79% compared with an OECD average of 74. Are people happy with that? Pretty much average. Are there unmet needs? Slightly worse, but overall pretty average. Are you getting this picture yet? When we get to quality of care, we've got 4 different indicators there. Prescribing, pretty much average. Primary care, we've got avoidable admissions to hospital for various chronic diseases, for asthma and COPD there, a little bit worse than average, but not dramatically so. AMI mortality, 30-day mortality, pretty much on average. Mammography screening could do better, but not that different from the average. And through to resources, health spending. 2019, pretty much exactly on the OECD average. Hospital beds, quite poor, not yet in the real area of looking absolutely dreadful. Doctors, again, pretty poor. Nurses, pretty much on the average. Right, why have I gone through all that? Lots of talk there. I didn't count how many times I said average, but that's the point I'm wanting to make. Average. Outcomes in the UK are average. Resources, actually, the health spending in the UK compared to the OECD, or if I made that the EU average, it would be very similar. I mean, it's basically average, a little bit higher than average. And that means if you've got the outcomes being average and the resources spending being average, that by definition implies that productivity is about average. So we have in the UK, an average amount of resources are devoted to health, and you get an average set of results. Is there any surprise there? I don't know. And this is why I suppose from the outside, some of the debates in the UK with people sort of saying, yeah, the NHS is the best system in the world. Well, no, it's not. Clearly, there are systems which perform much better. Is it the worst system in the world? Is it staggeringly bad? No, it's not. It's an average system compared with other developed countries. You've got an average amount of resources delivering an average health system. And you know, I think this idea that somehow the UK is very different from other countries. Well, in some respects, yes, all countries are unique in their own different way. But it's not that the UK is standing out in many particular ways. Indeed, of all 38 OECD countries, when we look for those 19 indicators that I've just shown, and we look to see how often is a country round about 0, or how often does it go above 1 or below -1, the UK is the most average country of all 38. Only once in those 19 indicators did you see the UK show performance more than 1 standard deviation away from the average. And that makes it the most average country in health in the OECD. Now, is that good enough? Well, of course it's not. I mean, I did talk about the membership of OECD for a reason. The average in the OECD in many of these areas is affected by the fact that you have countries like Mexico, Costa Rica, Chile, Colombia now being members. Turkey are members of the OECD. If you compare yourselves to France and Germany, it's going to be pretty clear in most of these areas we're going to be performing worse than France and Germany. I'll show you some more detailed numbers in 1 or 2 of these areas later on. So that's the pre-19 story. Oh, I should say one other thing. One area where it's not one of our 19 key indicators, but where the UK does very much stand out. It is one of the 3 best countries in ensuring equity of care. In other words, the socio-economic differences in access to care are amongst the top 3 in the OECD. There's very little difference in access to care by socio-economic group than in other countries. That's an important point. It's not one of our 19 key indicators, but it is a very important point. I should acknowledge it straight off. Let me move to COVID. There's no point in looking at reported COVID deaths. They're pretty much garbage in terms of international comparisons. So many problems in recording COVID-related deaths. I think the only way that you can actually talk about how systems, how countries performed is by looking at excess mortality. Has its own problems. I'm not going to say this is a perfect measure, but in terms of how the UK did, it's probably slightly better than most people in the UK expect. 13% more people on average died in OECD countries than you would normally expect during the COVID period. UK is, if you like, in the third group. I mean, obviously Mexico, Colombia, it's a catastrophe. Then you have a group of Central Eastern European countries with the United States where, wow, incredibly high numbers. And then there's a whole set of countries, developed countries, with roughly the same sort of performance, that sort of 10 to 15% excess mortality. And the UK is one of those. Obviously, there were some countries did far better. They're over there to the right-hand side of this graph, including some of the countries which have health systems which are the most similar to the UK system amongst all developed countries when you start looking at the Nordic countries. But you know, to some extent, it's obviously it's a tragedy and a catastrophe what happened. UK, it's compared with other countries, did okay, pretty average again. Obviously, as we all know, that's not the end of the story. We know that the long-term impacts of COVID, or the short-term impacts of COVID, has been this massive strain on health systems. One of the things we're hampered here is that we can't get waiting time data for the UK on a comparable basis to other countries. Very annoying, happens increasingly, in fact, with the UK, that going in your own direction in terms of developing health statistics, and it really does affect how well we're managing to compare the UK. But anyway, what I've got here is, first of all, on the left-hand side, median days for hip replacements, and unsurprisingly, you've seen a growth in waiting times in all countries where we can collect this sort of data. The sort of increase that we're seeing, if I then go to the right-hand side and look at the things like the median wait for in the UK for treatments and the number of people on the list, it's pretty similar to what we're seeing there in sort of Hungary and Ireland, something over a 50% increase there. So, you know, that what it's done to waiting times in the UK, although we can't be entirely comparable, it looks pretty similar to what's been going on in Hungary and Ireland. It looks pretty average. There are some countries which have done better. Obviously, there have been big increases, as you can see, in waiting times in places like Spain and Portugal, bigger, in fact, than in the UK. So certainly the strain there is clear. The other thing that I have to point out on the COVID period is this remarkable change in health spending. The surge in health spending in the UK was much, much higher than the increase in health spending in the OECD. Indeed, it was the highest jump in spending as a percentage of GDP. Now, that is, of course, the combination of the fact that the drop in GDP was larger in the UK than in most countries. It affected our economy more, but also that genuinely there was a big, big increase in health spending. The net result of that was that for a brief moment, it looked as if the UK actually had higher health spending as a percentage of GDP than in countries like Germany and France. And indeed, it probably was true for France in 2020. It's not been quite true. There's lots of revisions going on to health spending, as you know, the statisticians churn through all the data that's coming from countries. So in fact, the UK spending has been adjusted down slightly from where we thought it was, and German spending has been adjusted up a bit more. So we do still spend less as a percentage of GDP than in Germany. But still, there has been this big increase in health spending during the pandemic. This is the point where you're all thinking, yeah, but it went on a test, track and trace system, which didn't work. Yes, I know, but this is just purely doing the accounting of how much money did go on health. It is misleading, of course, to just look at a percentage of GDP. And let me just give you the sorts of numbers that means in terms of spending per capita, because Germany and France actually do have a higher GDP per capita than the UK. And so, for example, in 2019, the UK was spending about £3,300 per person during the year. France spending £3,950, Germany £4,883. In other words, to catch up with German levels of spending per capita, we would have to spend would have had to have spent in the UK an extra £100 billion. By 2020, because of this big surge in spending, UK was spending £4,000 per person, up 20%. France, it was just up 7%, so 4,236, and Germany went up 5%. So you were talking about £5,125. So although the GDP figures look quite similar, spending per capita still massive differences across the different countries. Let me move on to talk about the three key challenges. These are chosen because I'm looking at the UK, though in fact, you could use these three challenges for the majority of OECD countries as being the key challenges. But the UK is maybe stands out in a few ways. So the first one is the lack of capacity, the lack of resources in the health system. Yeah, the hospital beds, the policy has been in the UK and elsewhere, of course, to try and reduce the number of hospital beds where at all possible. They're expensive, they're not always the best way of delivering good quality care. Still, the UK is particularly low. If you look at the countries lower than the UK in the amount of hospital capacity in 2019, we are talking about Sweden, interesting, but then the other countries are countries that we wouldn't normally want to be compared to. And some of the countries where we do think they coped with the initial stages of the pandemic better, they did just have more hospital beds in place. And I should say this is also ICU beds. If you look at ICU beds, we're only just managing to collect this on a comparable basis, but pre-COVID, England had about 7 ICU beds per 100,000 of the population. That's half the OECD average, and it's a quarter of the levels that's available in Germany. Now, I should say, I don't think Germany's a good example there. It definitely does have too many hospital beds. But still, I think there is a case that the UK has gone too far in reducing hospital capacity, and that has affected how well it was able to cope during the pandemic and maybe even beyond. This is a chart that I think I show pretty much every single presentation that I do in the UK, and I make no apologies for that. I think it is the critical one. I mean, yeah, we can look at hospital beds. There is some correlation between hospital beds and how well countries performed during the pandemic. There is a much stronger, indeed, the strongest correlation that we can find in terms of how well countries performed during the pandemic between the quantity of the health workforce and outcomes. And this, of course, is where the UK stands out. So if you're in the left-hand side, it's because you have a lower number of doctors compared to the OECD average. And if you're below the line, it's because you have a lower number of nurses compared to the OECD average. Now, I don't want to be rude about the countries in that bottom left quadrant, but again, I wonder whether that's really the set of countries that you want to be comparing the UK with. Basically, the UK has a very low number of doctors. That may surprise you. And indeed, if I'd shown this chart a few years ago, it would be even worse than it currently is, because yes, there has been over the last couple of decades a near 50% increase in the number of doctors per capita. But there has also been a 30% increase in the rest of the OECD. So it's caught up a little bit, but not much. In contrast, basically nurse numbers have stayed the same in the UK over the last 20 years. Rest of the OECD gone up by about a quarter per capita. I think you can see the consequences in the way that the UK health system is performing at the moment. The number of new trained nurses entering the register relative to the population is much lower than the OECD average. In 2019, for example, it's about half the level of nursing graduates per capita than countries like Australia, Switzerland, Korea, Norway, US. You've got I saw the RCN survey that just came out recently, 83% of their respondents saying not enough nursing staff to meet all patient needs safely on the last shift, 83% of them, 25% of shifts, only 25% had the planned number of registered nurses, and only 18% of the respondents said that they had enough time to provide the quality of care that they wish to do. I don't think there is any way around this. The UK is facing a big shortage, much bigger problem of healthcare workforce than in other comparable countries, and it's a major problem. Going on to a second area, I do want to talk about primary healthcare. You know, this is not an area where the UK necessarily does staggeringly badly compared to other countries, but it could do, I think, a lot better. Here I'm just showing the avoidable hospitalizations. I referred to this briefly in the opening slide. The UK does pretty well on diabetes, but actually very poorly on COPD and asthma. And again, I think, you know, you add that up to the fact that that survey recently was done that said half of respondents had difficulties in accessing out of hours care for primary care. And you know, of course, that whilst doctor numbers have been going up, the number of GPs as a share of all doctors has fallen rapidly in the UK from being a third of all doctors in 2000 to just a quarter of all doctors in 2019. Do feel that the primary healthcare system is an area where further attention is needed. We see it as well when we start looking at access to primary care for the elderly. Yeah, you're about the OECD average there, but you can see there's a number of countries which do much better in terms of stopping elderly people going to an emergency department for a condition that could have been treated in primary healthcare. Yes, it's relatively old data from the Commonwealth Fund, but I don't see any reason to think that this has changed more recently. And the last area I'm going to highlight is, of course, social care. You know, the UK again, in some respects, it's surprising about how poorly performing in some aspects the UK social care system is, because you know, the amount of spending is not particularly compared with OECD countries. Probably as some of you are thinking, yeah, but it's mainly private spending. That again is not actually true. The England at least spends spot on the OECD average in terms of the amount of money that's coming from the public purse compared with out-of-pocket spending. It does change a bit when you get to people who have more severe needs, and their UK spending is well below, public spending is well below what happens in other countries. And maybe that's the issue. It is about the balance of where spending is going on social care in England. But you know all this, massive problems in the social care system. It clearly is a broken system at the moment, badly needs to be helped. You know, we've got, what is it, about 13% of all acute hospital beds being occupied by patients who no longer need to be there. That's March 2022, 13%, and it's a massive, massive number. I'm not going to spend time on this. I do also just want to note that we do focus, I think, in the UK very much on resources going to the social care system. And I think that is right. there is an issue of resources. But I think, you know, the way that the system is broken goes beyond resources. I don't think this is a system that integrates well with the healthcare system. There are examples around the world, I think, where policies have been put in place that have worked very well at improving the performance of the health system, some of which have actually been tried in the UK. I noticed financial incentives there. Didn't work anywhere near as well as happened, for example, in Norway. And I think that's something that needs to be looked at. Why is the system not performing, even given the resources that are going into the social care sector? Final chart, I need to finish it up somehow. I'm coming back to resources because I think that is such a central issue for the UK. We've tried to assess how you could actually leave your health system in a better situation than it was in 2020 when the pandemic struck us. You know, what would need to be done to the health system, healthcare system in particular, in order to be able to respond better to a crisis such as the COVID crisis? In our view, the UK probably needs to spend about 1.5% of GDP over the next 10 years or so in order to get its health system into a state where you could say the health system would be able to cope better than in 2020. The sorts of things needed, absolutely not, no surprise to anybody, an expansion of the workforce, some increase also in salaries there. That's particularly actually in the nursing sector and to some extent the care sector, not so much on the GP or the doctor's side. A lot of foundational spending, you know, that's the core stuff that you're doing in terms of infection control, vaccination, core equipment, and indeed the physical infrastructure. There's clearly spending that needs to be done in the UK there, and making sure. Sorry, that was containment I was talking about mainly. But in terms of the foundational, that's the investments in infrastructure in particular. So we reckon about 1.5% of GDP would be needed over about 10 years in order to make a material difference to how well the UK system could actually respond to something like a COVID crisis. Wow, that was a lot to get through, but there's so much that I've left unsaid. I am sure that we'll get through some of this in the discussion. So thanks very much for your time there.
Mark, thanks so much. That was excellent, clear presentation. Mixed picture, average a lot of times. Some areas where we do better, some where we do worse. I should come back with two really quick clarification questions and then we'll go to the other two. Both on resources. So as you said, looking at proportion of GDP, how much you spend compared to your GDP on health is what we commonly do. We look pretty average. Then when you compare spending per person, looks like we spend quite a lot less than some comparable countries, probably been doing that over a decade. How does that affect your assessment of performance? Is that all bundled into your middle of the pack type assessment? Just tell us very briefly about why we use those two different versions. And second, crikey, 1.5% of GDP, that's a lot of money, isn't it? My maths isn't good enough quickly to work it out. Someone else needs 20, 30 billion. It's a chunk for us. Is that your assessment for us, or is that across OECD countries generally? You're saying, look, you're going to have to boost spending to become more resilient and better prepared. If you could just quickly come back on those two, that'd be great. And I'll go to Irini. And Mark, your presentation was mostly extremely clear. A couple of points, your mic came in and out, so you can stay close to that'd be great.
Okay, sorry about that. Yeah, I will stay a bit closer to my machine. As I said, those of you on the pre thing, I'm not on my normal machine, so I have to work out how well this one's working. My machine collapsed this morning, very, very annoying. Anyway, the first question, look, it's extremely difficult, isn't it? Because on the one hand, the attraction of GDP is that a lot of health spending you'd expect to be affected by the level of development in a country. So salaries, for example, obviously richer countries have higher salaries, you know, so you would sort of think that GDP makes a better comparison when you want to look at things like that. On the other hand, there are other spending, for example, pharmaceuticals, maybe medical devices, where you're price takers, you know, regardless of your level of development, to some extent, what you're spending is going to depend on just international markets or how well you manage to negotiate, in which case looking at the absolute spend is more relevant. I think the honest answer, you know, it's the most annoying answer I could give, but it is the truthful answer. You do need to look at both. You know, just focusing on GDP, you know, it jumps around, as you've seen. You know, UK spending in COVID went up massively during COVID. Did that really mean that there was more money going into what people normally think of, you know, in terms of frontline spending? No, it was partly due to collapse in GDP, partly due to other spending taking place. You know, I think having a broader picture of looking at both is probably necessary. GDP tells you a lot, but don't get obsessed by those GDP figures. It's also the absolute levels as well. The 1.5%, you know, we've been doing this for each country individually. There is no country where there isn't some sort of spending could have improved things. But the best performing countries, we are talking about maybe 0.8% of GDP. The average need is about 1.4% of GDP. What a surprise. The UK is pretty much spot on the average because it's an average performing health system with an average level of resources going into it. No surprise there. I mean, if you spend an average amount, it's not a surprise you end up with average outcomes. And so, yes, it's 1.5% is pretty typical for other countries as well, but it is actually based on what's going on within the UK. I should say it's quite a quick and dirty thing that we did. I'm sure there will be lots of you know, digging through it. We can come up with something much better and hope that people in the UK are doing that. But from the international comparison side, 1.5% is our best estimate at the moment.
Thanks, Mark. People are going to remember your key message, average. Irini, can I come to you? So you've done tons of work on international comparisons. You also did a big study, I think it was in the BMJ 2019, that looked at a smaller subset of countries. I think it was 9, maybe 10 compared to the UK. So maybe you could give us your reflections on Mark. So I guess one is just your overall assessment of how we do. Do you agree? Any areas we do better or worse that stand out? And then maybe you could talk about some of the issues of doing this work, some of the challenges of really getting a meaningful comparison.
Yeah, thanks, Mark, for those insights, and Hugh for kind of guiding the discussion here. I just want to come in on something that I think both of you have mentioned about how tricky it is to do international comparisons, right? I mean, and I think, Mark, you've talked also about how hard it is to find who you're comparing to and what you're comparing on, and of course, where you are in a comparison is going to be very much determined by who you're comparing yourself to and what you're comparing yourself on. So that, you know, it's interesting here, we're looking at a comparison of the UK to the OECD, a set of, you know, high income countries, about 38 countries. But, you know, you've pointed out repeatedly, I think, in the presentation that if we look at who's in some of the same areas and, you know, are those who we want to compare ourselves to. And so I've done also comparative work where we might take a subset of the OECD and think of the countries that the UK often compares itself to, maybe more of the higher income countries in the OECD. And there, you know, you have, I guess, a different frame of reference. And this is what's great about international comparisons. They're a great way to benchmark yourself, to give yourself a frame of reference for how you're doing relative to maybe the countries that have similar challenges, or you think have the same you know, amount of resources, or believe they should spend similar amounts of resources to achieve certain goals. And there, you know, maybe your assessment of average would change if you change the group, right? So if you think about health spending, you know, it's about average for the OECD, the 38 countries. But if you look at the very high income countries, the UK is on the lower end, you know. And if you look at outcomes, you know, again, your average there might change. And if you look at those countries, I think, and there's been other international comparisons that have highlighted this recently, maybe the UK is doing not so well. And so, you know, this average very much depends on who you're comparing yourself to. And then another point about the average that I want to comment on is this is also an average of the UK, right? So it's not just an average within the OECD, we're also looking at an average within the country. So if we take any one of these metrics, there's also going to be huge variation, I would say often bigger than what you see across countries within the country. So if I just take one of these metrics, because we were talking about outcomes, let's just take life expectancy, right? And we can have a different discussion about how much that represents the performance of the health system. But if we took life expectancy, I think the average that the UK was about 81.4 years. I made a note of it. But if we looked at this, and I was looking at this before the presentation, of what the variability is within the country, we have, almost the entire spectrum represented, where we have regions in the north that have life expectancy of 77 years and regions in the south that have life expectancy closer to 83 years. So you have almost that entire distribution that we see in the OECD within the country, right? And and here I think there were some questions I saw in the Q&A around equity of outcomes, and I think equity more broadly. Mark, you highlighted, that the UK has very good equity and access, but and if we think about outcomes and we think of these average outcomes that have been compared and discussed a lot recently, there's a lot of variation within that also across the country. Also variation in the uptake of healthy behaviors, variations in a lot of social determinants that we know are going to be linked to these outcomes. And so I think if we think about these outcomes, there's a couple questions we want to ask. One is this average, how does it break down across geographies, across populations, demographics, right? And that can, these comparisons are useful, and then they can help us then dig down further within our own kind of data to try to understand where to look further in these. And the other question is, I guess, if we're looking at outcomes and we think of even average outcomes or the distribution of outcomes, how much are these outcomes the product of the activities of the health system versus investment in other areas as well? So I talked about the social determinants. That's one aspect: housing, jobs, education. The opportunities to achieve kind of better life. Also, genetics are different across countries. How much are we able to account for that? Also behaviors, and we see that there's also gradients in the uptake of different healthy behaviors. So I think it's important to consider that, and when we are comparing one health system to the other, of course we should look at the outcomes that we're achieving, but we should be careful to put all of that on the performance of the health system versus investments in other areas. I mean, I think the question maybe to ask then is, how much is the health system advocating for changes in these other areas as well that can be very important for improving outcomes overall? And that's maybe something that we can come to more, because I did see a few questions in the Q&A around that. Another, I guess, point that I wanted to touch on was these kind of highlights of the key areas to focus on. These were very much kind of what we concluded in our BMJ assessment in 2019. The capacity constraints, definitely. And when we compared the UK there, it wasn't to the entire OECD. I believe it was to 10 other kind of more high income countries from the OECD. The capacity constraints were more evident. So the nurse numbers particularly were quite low compared to some of the other very high income countries. And nurse remuneration was quite low. Mark, you talked about also nurse graduates. And so I think these capacity issues, they've been there before the pandemic. I worry about also how the pandemic exacerbates this with, high instances of burnout. So I agree very much that this is a key area that of focus and to work on to make the system sustainable and resilient. And then the other two areas I really briefly wanted to touch on was this the social care, primary care areas that you mentioned. And we recently did a comparative study actually with the Health Foundation as our UK partner, where we took a different approach. So instead of looking at kind of the population or patients of a particular diagnosis, we tried to follow certain types of patients throughout the system. So really what we're trying to get here is that integrated care and kind of how you experience care as a person who's in and out of the system a lot. So we looked at a frail elder and an older person with complex multimorbidity as our two kind of tracer people through the system. And there were some interesting insights here across the comparison that we saw. One was for the frail elder, where we took as our exemplar somebody who had a hip fracture and looked at them for a year as they go through the system. In the UK, we had the longest average length of stay in hospital after their initial admission, much longer than the other 11 countries that we were looking at, and also the highest levels of inpatient mortality. And they had a higher proportion of patients who were never discharged from the hospital, but unfortunately died in the hospital. And this was interesting because in a lot of other countries, there was discharge to community rehab, institutional rehab, and we didn't have links to community rehab data or links to social care data to really examine this. And so this really highlighted kind of two issues for me for thinking about where to look in England in the future. One is just the necessity really to have linked data to community care, to social care, to really understand, if we want to understand integrated care and how the health system works for those who have the most need, we need to be able to follow them. Otherwise, we have these snapshots and they can give us indications of where to look, but they can't help us really find the right answers. The second was that there appeared to be kind of bottlenecks there. So countries that had more institutional and community rehab, where we had the data to look at these patients, had shorter hospital length of stays, had patients moving out more quickly, and that could be both desirable for patients. They also had better outcomes for patients. We can't say that was linked to that, but that would be really interesting to look at. In our older patient with multimorbidity that we looked at, it was the primary care component that was interesting. A lot of use of primary care. So that was a patient with congestive heart failure and diabetes. And so that's where you would expect them to get their care. But it's also interesting that they didn't have as much use of specialist care. And there's a great long read that the Health Foundation has on the website about the results from this project that highlight kind of for this group of patients, the lack of specialist referrals to cardiac rehabilitation. So again, we come to this rehabilitation and specialist care. And so, Mark, in your point about primary care, one thing that I was thinking is also how much is there a strain on primary care because I guess maybe of less use of other areas of the system like rehab, like specialist care, that really puts a lot of pressure both on those providers and on that setting. And the outcomes, at least for the cardiac rehabilitation, show that would be that is also associated with better outcomes. So how can we improve these pathways of care as well to take some of the strain off of primary care and make more use of other parts of the system that might be appropriate for certain patient types? So those were, I guess, a first set of maybe a lot of reflections. But thank you for some really interesting insights there.
Oh, and thank you for some excellent reflections. Really helpful and add a bit of color to Mark's reflection. So Tim, we've got some really good questions coming in too that I want to ask everybody, but Tim, let me come to you quickly and try and help us link this to what's going on in England now, current policy debates. How are these often used? What can we actually learn for the English context, and what's some of the limits of what we can learn? So Tim, over to you.
Thanks, Hugh. So I've prepared some thoughts. I'm sure they will be distinctly average, given what we've heard so far. So I think it's worth saying that the UK's health system is clearly not in a great place right now. Responding to COVID put health and care services under tremendous pressures. The challenges of getting back on track are really, really daunting. As I think we've heard from Mark and Irene, the UK's health system went into the pandemic in a pretty weak state in the first place. 2020 followed on from a decade of austerity. We'd seen life expectancy start to falter, inequalities starting to grow. Plus, particularly in England, we'd seen some quite long-standing policy failures on social care reform and workforce planning. And while COVID put all health systems under pressure, the UK in Europe was pretty badly affected by the virus. Not uniquely, but I think the pressures on the NHS were arguably at least as great as most places in Europe. We're really starting to see some of the consequences of that coming through. So we've got a workforce that's really stressed, exhausted, and demoralised. We've got substantial backlogs of delayed care with hospital waiting lists of 6.4 million in England alone. We're seeing continued strains on services, giving rise to some situations where quality of care is falling below expected standards and is sometimes unsafe. And we're also starting to see some increased demand from the longer term impacts of the pandemic on our health and well-being. The public is understandably pretty dissatisfied. The latest British Social Attitudes Survey found public satisfaction with the NHS had fallen to its lowest level since 1997, largely due to waiting times and staff shortages. Our own public polling with Ipsos has found some very similar issues. So ministers are clearly feeling the pressure to do something. The big question is what to do. So ideally, the policy-making process would start by identifying what is the problem or the set of problems that we want to solve. This is one of the places where international comparisons can really cut through and can add value. There are various ways of looking at how well the NHS is doing, but few really resonate in policy, politics, and the media as much as talking about, on the one hand, how the UK is world-beating at this, or on the other hand, how we're lagging behind our neighbouring countries on something else. I think done well, international comparisons can be a really positive source of learning for policymakers. Comparisons put a spotlight on differences in policy and performance, and can highlight some of the potential opportunities that we've got to learn and improve from other countries. And there's also scope for mutual benefit. No country has yet cracked the creation of the perfect health system that consistently outperforms everyone else. So there's something for everyone to learn. So I guess the question is really, how do we not only do international comparisons well, but how do we use them to make for better policy making? And I think this is, the way to think about this is, how do we use international comparisons in policy making in a way that is complete and as balanced as possible? So 3 points. I think the first is, as Irene mentioned, we always need to remember the importance of context. Health is about much more than healthcare. All countries face different health challenges, have different needs for healthcare, and have different levels of resource that can be applied to meeting those needs. Adjusting for all of these differences is really difficult, but it's really important. Secondly, we need to avoid cherry picking and make sure that we're using all of the data that's available. Health system performance is multi-dimensional. I think we've heard a bit already about, if we compare ourselves to some of the countries that we would see as our natural comparators, we find that the UK is relatively weak on measures like cancer survival and mortality following hospital admission for heart attack or stroke. These are really important measures of quality, and the international comparators are further proof that we need to keep looking at how to do better. But they're not the only quality markers. There are other conditions, for example, on diabetes, where the UK compares very well. We seem to have a relatively strong system of primary care in many respects. Prior to the pandemic, we were about average on waiting times for common types of surgery. We weren't the best, but we were nowhere near the worst either. And the NHS has consistently done very well at protecting people from the financial consequences of ill health. Now, that might not be what we immediately think of as performance, but it's important, and it isn't something that we can take for granted. Finally, as well as making sure that we look at all the data that we have, we need to remember that we don't have all the data that we would like to have. So thanks to organisations like the OECD, the Commonwealth Fund and others, the range of data that we have to inform international comparisons has improved quite dramatically over the last 20 or so years. But there's still quite a lot more to do. Most of the data that we have is quite tied up with what happens in hospitals. But the majority of healthcare, certainly in the UK, happens in primary and community care. There are 300 million GP appointments in England every year, only about 25 million visits to A&E. We know quite, a reasonable amount about the quality of care for major acute illnesses that threaten life, than we do about the increasingly prevalent long-term conditions that have a serious impact on quality of life. There is very limited data about mental health and mental health care. Some aspects of health system performance are fundamentally harder to measure, but that doesn't mean that they don't matter. So in terms of using international comparisons in policy making and thinking about how this can help shape and guide NHS reform, I think we should see them as very much a starting point. Think of them more like the warning light on the car dashboard that tells you that there might be a problem, but that doesn't tell you what the problem is, let alone give you step-by-step instructions on how to fix it. It can be really easy to notice the obvious differences between different health systems, but attributing differences in those performance to some of those obvious differences can, without looking for alternative explanations, is possibly risking poor policy making. Having identified where we do less well, we need to look at why that is and why do other systems do better. Is it linked to differences in context? Is it about differences in structures and systems, differences in how we deliver health services, different levels of resources and investment, or differences in just how we define and collect data? Or is it a combination of all of the above? And in doing so, we shouldn't overlook the strengths of our system and the positives around our wider situation. Public support for the founding principles of the NHS remains very strong, despite current frustrations around access. Patients are still fairly satisfied with quality of care they get when they can access it. And history does suggest that the NHS is capable of delivering relatively good and equitable access and making some quite big improvements in performance over time when it's properly and consistently resourced to do so. We also need to remember that health systems are pretty complex beasts, and changing systems to improve one aspect of performance may have unintended consequences for other aspects. So I think, fundamentally embarking on radical change without a robust diagnosis of the problem, a credible logic model for how changes will lead to improvement, and an understanding of the risks of making those changes, that's a recipe for bad policy. Doing the opposite is hopefully a recipe for better policy. I think international comparisons can be a really important part of this, but we do need to remember that they are good at generating questions. They rarely offer policymakers easy or particularly definitive answers.
Thanks, Tim. Excellent set of reflections. So from all of you, we've heard it's complex, it's hard, fair enough. We completely get it. But we've had some really good questions about some specific areas where it seems like there's some lessons for us here. So I want to ask questions I've clumped them together in a few areas. The first is capacity. So we've had lots of questions about beds, staffing, nurses, numbers of doctors and nurses. So the question is sort of twofold. One, is this one of the biggest areas where we can clearly say, from looking at these data, constrained capacity in our health system is contributing to worse performance than we'd like? So is that one of the obvious lessons we've got to boost capacity? And is it as simple as the number of things you've got, or is the lesson a bit more nuanced? So you talked about Germany, Mark, many more doctors, nurses. Is it about how you use the capacity as well as how much you've got? So let me come to a couple of you to talk about this set of capacity issues. Is that a clear lesson? What do we do about it? Mark, let me come to you first.
Fantastic. Yeah, I mean, I'm tempted just to spend, if you don't mind, just 2 minutes just saying how much I absolutely agreed with the comments of the two commentators, because I think they're absolutely right. Look, what we do with international comparisons, we often say what we're doing is we're holding up a mirror, right? So this is how you look to an outsider, kind of no interpretation. It's simply a mirror. Now, what you make of what you see in the mirror is much more difficult, and certainly what you do to respond. I can't put on your makeup for you. You're going to have to do that yourself. I can hold the mirror. I can't do anything more than that. And I think that's quite important. I mean, these comparisons are very, very basic comparisons. They're the numbers that come out. They're not showing any causal effects. If you want causal effects, it needs to be something much, much more nuanced. And, you know, Tim, you're absolutely right. I mean, I think it was you, but I think Irene touched on it as well. Often the comparisons that we're making are what we can compare, right? They're not what we want to compare. And that's incredibly important. And this is mea culpa for me as well at the OECD. A lot of what we do is that we measure the inputs into the system. We're very good at counting how much we spend on different things and how many doctors there are, and this is coming to your question, and how many nurses there are and so on. We're okay at some outputs. We can count how many times people actually have contacts with health systems and how many operations of different sorts are done. But in terms of outcomes, what we really want, we're actually really quite limited. We have a few measures, you know, yes, 30-day mortality after AMI, or, you know, various errors in surgery or whatever. But we do need to go much further. And we are, actually, there is a big process underway at the moment that most of the countries in the UK are part of, called the Paris project, which is going to have a survey based on primary care practice, looking at various chronic conditions and looking at how people actually are reporting their outcomes in a comparable way across countries. And I think when that data comes in, it will be a bit of a game changer, and we'll stop focusing quite so much on how much we spend and how many doctors there are, and, you know, assuming that it has a direct link on outcomes, and actually be able to demonstrate what the outcomes are. Now, that's a complicated way of getting to your point, you know, Hugh. It's not ideal to be looking at things like capacity. We have an ongoing row. I mean, when I do these sorts of presentations for Germany, people get very offended when I say they have far too many hospital beds. They do. There's all sorts of reasons why they have far too many hospital beds. And you can see the consequences of having too many hospital beds in their data, because they do a truly absurd number of elective procedures. They do, for example, about twice as many hip replacements as France. France does twice as many hip replacements as the UK. I don't know what the right number of hip replacements is. It's somewhere in between what happens in the UK and what happens in Germany. We don't quite know where, but certainly if the capacity is there, you find that the capacity is used. There's very few health systems which have very low use of capacity. So this is not a straightforward thing to say that we need more doctors and we need more hospital capacity. I feel reasonably confident in saying the UK has too few of both, looking at the way that discussions go on, at people's experiences of the health system, but I can't tell you how much fewer it has at the moment. That's how much fewer than it needs it currently has. And that is a problem. I absolutely agree.
Thanks, Mark. So I'm actually going to ask a different question now to you, Irene, because we've not got a huge amount of time. So another area that seems clear is on some outcomes, some population health measures. We're doing worse in some other countries that we'd like to compare ourselves against. There's various questions about spend on prevention, social factors. So what's the relationship between those measures? Are we really talking about things that are affected by spending on housing, income support, other parts of our social security system, or is it about the health system? How does that play out in the English context? So if you could talk a bit more about that, that'd be great.
Yeah. So again, that's it's hard, just to echo Mark's points, from any of these comparisons to draw anything causal. But one thing that we did look at is just some associations to understand the direction, you know, of spending in social programs. So not just prevention, health prevention, but things like housing, education, and health spend. I mean, those I guess spending on social programs is associated with better outcomes, health outcomes, you know. And so of course, and we know there's a whole social determinants literature around how your opportunities for good housing, having a more income, better jobs, and can help your opportunities for having better health. Now, how do we differentiate that from the contribution of the health system? So we have different ways where we try to measure the contribution of the health system. So we can look at subsets of conditions that are more kind of treatable or amenable to healthcare, as we call them, but those are not perfect. How much of ischemic heart disease is due to factors that, genetic factors or behaviors, and how much is the contribution of the health system? There's going to be both in those measures too. So it's very tricky when you look at outcomes, especially across countries where all of these factors vary, to determine how much is the health system. In some work that we've done, so again, touching on the pathways of care, where we're able to follow distinct patients, and here we're more comfortable kind of thinking about the quality of care they receive in over time, and then looking at their final outcomes. When we looked at our hip fracture patient, we looked at some quality metrics. We had limited measures of outcome. As Hugh was saying, we rely sometimes on quite crude outcomes. We looked at mortality at different intervals, but we did also look at other aspects of their care. So one thing we looked at was how quickly, once patients present to the hospital with a hip fracture, do they receive surgery, which we know can be associated with outcomes. And the UK did quite well there. They had a good proportion of patients receiving surgery within 48 hours, but then they also had the highest, inpatient mortality and 30-day mortality. So it's not to say that you can't have bad outcomes and also have good quality care, or have good access to care. There's a lot of factors that contribute to outcomes. So it could be that the patients were sicker when they came in. We talked about fewer hip replacements in England. Maybe there's more osteoarthritis in the population and older people, and you have sicker people coming in. Maybe they're getting, so all of these factors, we need more work to disentangle. How much is it that there's other factors that contribute to the broader health that make patients maybe sicker when they're coming into contact with the system, versus the system itself not performing. And a lot of the quality measures that we look at, we can find instances where the UK is performing very well. And so it's hard to look at outcomes to give you an indication of how the system is performing. And I think the key here is to use the international comparisons as a benchmark, maybe to focus the efforts on where to look first, right? So where do we see that quality might be underperforming? And maybe that's the area that we target on first, in terms of thinking of that's where the NHS can do something to improve health outcomes. And maybe in other areas where we don't see these measures of quality underperforming, maybe that's where we need to focus outside the health system and think about what are the determinants that can affect how ill these populations are when they come into the health system, and where can we make efforts to change that. So we can use it both ways. We can use the information from the health system also to rule out where we think it's poor quality of care, and it might be other factors that we need to focus on.
Thank you. That does help. There's a question there in the chat about the link between what are data on equity of access to healthcare services, and then what's the link with equity in health outcomes. And you picked up on that too. But Mark, I wondered whether you wanted to comment too on the broader point about the relationship between social spending and health spending, and whether that makes a difference, and whether really we should be looking outside the health system. Does everyone to be improving outcomes? It's actually investing in a wider set of services.
Yeah, I mean, it's the most difficult thing about doing spending comparisons across countries is the borderline of what's social and what's actually healthcare. And we jump through various hoops. There are clear definitions all to do with activities of daily living and instrumental activities of daily living and so on. But that doesn't mean that in practice you don't find people providing care which is sometimes social care and sometimes healthcare, and that messes up quite badly the border, or rather messes up, it fuzzies the borderline between what is counted as health spending and what is counted as social spending. The figures that I showed are basically the figures that we get from countries. They're validated to the extent that we can with a big approval process that goes on with international statisticians, but still, there's some fuzziness there. One of the things you can do is just add the two things together and look at total health and spending together and see how that actually compares across countries. And we do that sometimes. But basically, I think it's just pretty clear. And you don't need to go into extensive economic arguments here, that a social care system which does not function passes on costs to the health system. We see that very much in the UK with, obviously, the bed blockers is the main way that that comes through. In other countries, it can be other aspects. In the United States, frankly, it's the only way that you can get some sort of social care for many people is via the hospital system. And so you do find people accessing the hospital system in order to access services which for say disabled children or something, or people with substance abuse issues, which in other countries would be tackled through the social system, are tackled through the health system. It's a minor but nevertheless significant reason why health spending is so high in the US. So I think you can make the case when you get down to the detailed examples of when social care systems go wrong, that they pass on costs to the health system. And that's really what I suppose what I would focus on. I mean, it is clearly the case at the moment in the UK, England, actually, let me be specific here, that the social care system is passing costs onto the health system.
Thanks, Mark. Okay, so we've got about 3 minutes left. This has been such a good discussion, it's gone too quickly. I want to ask one last question which has come up, and which is sometimes discussed in the media. There's obviously lots of different ways you can organise a health system. You can have a tax-funded one like ours, you can have a Bismarckian system where you organise it a different way, and sometimes international comparisons are used to suggest people should switch systems. I think OECD did some analysis about 10 years ago that looked at different types of systems, compared performance, and I think it found there's as much variation within types of systems as there is between them. There's no perfect health system, and really you should focus on how you use your resources in your current model and make it work. But Mark, I don't know whether you could give us a final comment on that before we try and close.
Absolutely. It's the most annoying thing that we get from these comparisons. The idea is, oh, should we wake up one morning and just, switch to the Dutch system or the Australian system or whatever? No, please, no. What a waste of time and energy that would be. No, there are examples of NHS type systems which work better, I think, than the UK NHS systems. There are examples which go worse. Similarly, for the private insurance, mixed models, all these different systems, there are good examples and bad examples. What you can guarantee is that if you try and switch from one system to another, you are going to spend years with people spending all their time looking at the organigram to try and work out how the bloody hell the new system works. And that's time that could be spent on improving the quality of care for patients. It is absolutely not the route to go down. I'm not saying don't reform things. Do reform things, but the idea that there's these kind of magic bullet out there, just if only we did the way that it's done in some other country in a big way, that everything would be solved. No, absolutely not. That's a thing I didn't talk about today, but an absolute other lesson from international comparisons. UK reforms or England reforms its system far, far too much, and it's one of the reasons why you don't improve your health system as rapidly as you should.
Thanks, Mark. That's a great way to finish. So I think the final takeaway is ignore those debates in the press and focus on that slide you put up at the end, Mark, about 1.5% of GDP extra investment. Work out where the resources should go, how we use them. Right, that's gone very quickly. I think we've done an okay job at answering some of the questions, but there's more to be done, so we'll return to this topic. Thanks so much for logging in, for watching. Thank you so much to you three for such great reflections. I'm sorry we could only really skim the surface. The webinar's, it's dark in here, move around. The webinar's been recorded, so you can watch it again, share it with colleagues, and sign up to get updates on future webinars we're going to be doing. There should be a link somewhere. But that's everything. Thank you so much again. I hope you found it valuable, and see you next time. Cheers.